I'm gonna share screen. Just a minute. Okay. Just a minute. For the yes. Okay. Do you see my screen?
Yes.
Okay, good. So this, I already discussed this like in the oh, that was Matt too. Sorry about that. I already discussed this with Matt too. But this, no matter how you like this channel, I mean this table or not like this table, it will come back over and over again. Okay, it will just haunt you. So so this one is like a super important. So um but if you know like a little bit of this it's kind of basics. So it's not really very extremely difficult to memorize this thing. But this one, this the diagram has to be in your brain. Okay, so that will save a lot of time. If you can retrieve, even if you don't really like memorize every detail of this, you can still retrieve probably if you just memorize if you know the like very big framework. Okay, but it's very bad. I mean, it's a really good idea. Utilize the first 15 minutes that you have a time to jot down anything like formulas and things like that. That time, 15 minutes is good time to you know just write down this thing in framework wise. Okay, so actually it's not very difficult to the memorize. Let me show you some the tips here. Okay, so basically from starting from cholesterol, right? And then I'll just go over the material. I mean, the important point is that um, the enzyme and the product, you need to distinguish these two. Okay, so here is the enzyme AIDS, right? Is enzymes, right? And then this is a anything is not AIDS, end with age is the product. Okay, simple, right? So you have to distinguish these two. So don't many times, like for instance, the 17, you know that 17, the 21, 11, but then, oftentimes they will ask you, 17, the sometimes 17 alpha hydroxylase, but sometimes they will ask 17 hydroxyprogesterone. Oh, then many people confused with the like, 17 hydropregnol with 17 alpha hydroxylase, which is different thing. Okay, so something that you have to distinguish between these two. So don't just say, "Oh, it's 17. I know 17." No. Okay, so you gotta distinguish between that. If you look at this carefully, it's not very hard to distinguish it because I mean reconstruct this the diagram. Okay, here cholesterol, right? First product is a pregnenolone, right? Let me first before you go further, let me let me like highlight the the enzymes. Okay, here is a 17. The 17 is right here and then right there. This is 17 alpha hydroxylase, right? Enzyme. Now then, the 21 hydroxylase is here. Okay, And then 11 hydroxylase is here. See, this 17 is kind of vertically. So these two steps will be blocked by the 17. Okay, and then there's another enzyme which is less popularly. It's a 1720 lyase. Okay, and then also there's a aromatase and 5-alpha reductase. All those that I circled right now is in the with red the color or pink color. That is enzyme. Okay, so then everything else will be the product. So you start with pregnenolone, and then look at this carefully. Let me use another color. This color. Pregnenolone, right? Pregnenolone, same. And then 17 hydroxy is added. Okay, because of 17 alpha. So that's why 17 is added here. And then also here 17 hydroxy is added. Same thing. Now here is a progesterone here, and then progesterone here, right? So basically, if you know progranulon, then it becomes a progesterone. Then you know that's the 17 alpha by the 17 alpha hydroxylase function that will make this turn to 17 hydroxy pregnenolone, 17 hydroxy progesterone. Okay, so know this. This is a very important thing because many times they will trick you by just confusing you by using the 17 alpha 17 I mean 17 just without even thinking that 17 I know 17. So that will make you the question wrong. Okay, and then from here to lyase. So when the 17 lyase 1720 lyase comes in, then dehydropia the drosterone. Okay, very confusing term, right? But DHEA, you know this one, right? You already know this, but when they say dehydro androsterone, I have no idea how to read this. But DHEA is the terms that you know already. Okay, so just they usually spell this out for long names to confuse you. Okay, so don't get tripped on that. Okay, and then after that 17, the reason that the 3 beta is not very particularly important is that because it will just apply to all layers. Okay, so it's even if it's okay, let me quiz you. If it's the 3 beta is deficient, what's going to happen? What do you think? If it's not there, then what's going to happen? This is a very important the concept. Why if it's not, if it's 3 beta, suppose if you don't have 3 beta, then what's going to happen? Can anyone tell? Guess? Any guess? If you don't have 3 beta, this enzyme right there, this enzyme, 3 beta enzyme. If it's not there, what's going to happen? Then what will be increased, and then what will be decreased?
Wouldn't progesterone be decreased and the pregnenolone would be increased?
Yes, true. Yes. But that's not the only thing, right?
No.
So this cannot go here, then where does it go? If this is not there, then you cannot go here, right? So it will be decreased, it will be increased. Yes, true. Then where does it go?
It would go more so to the cortisol and the sex hormones.
You sure? If it's not
No, you're
going
right.
there,
Well, because it would just be backed up there because it wouldn't even go there because all the
yes, yes,
stuff
yes,
is
yes,
there.
yes, yes. True, true, true. So basically, this path is blocked, all blocked, right? The one that I highlight here, right? It's all blocked. So this will go here, and then it will divert to shunt to here. So you will eventually have a progranulin high, and then 17 the hydroxy progranulin high, and then DHEA also high, right? Agree? Because nothing cannot be here.
True.
There's right. So that's kind of things are important. Okay, but the reason that this is not very clinically significant is that this doesn't is firstly this is very rare condition, and then even if it's the happening, this thing will be there, but this has a kind of weak weak the of the this every the mineral corticosteroid and the sex hormones functions. So that's why this is not really very particularly of importance. But you have to know this what will be the increase. This level will be increased, and then you will have low levels of these things. All of this will be low level. Low of this, low of this, low of this. Okay? So just basically they will test you, you know, this is not really kind of more likely kind of mathematics. So if you block this, where does it go? It will go here. That's it. That's what you need to know. Okay. So so we we discuss progesterone, progranulin, then becomes progesterone, and then with and then after that will be 21. So 21 will convert it progesterone with now it's deoxycorticosterone. Okay. Now, if you don't have this, what's going to happen? If you don't have 21, where does it go? This will not cannot come here, right? So cannot come here and cannot come here. So it will be diverted to the it will be diverted to the this way, this pathway, right? And then it will go to here, right? It will go here and then it will go here, right? So sex hormone will be increased. So 21 will block this, block this. So no mineralocorticoid, no glucocorticoid, but sex hormone will be high. Okay, that's the 21 hydroxylase deficient. Okay, what if what if we the I have a 17 alpha deficient? What's going to happen? If it's not there, then you cannot go here. You cannot go here, right? So it will go down here, right? Because there's no connection here, no connection here. So in other words, it will just go down. So in other words, 17 alpha, the hydroxylase, then 17 alpha deficient, then you will you will cause only aldosterone high, right? So when aldosterone is high, what's going to happen? What kind of symptoms you will have? Increased blood pressure? Yes. How about sex? Sex hormones. If the 17 alpha is deficient, then everything will be not there. Everything goes down, has down, right? No sex. Yes. So you will have a 20, I mean, the sorry, 17 deficient that will cause blood pressure and then sex. Blood pressure high, sex is normal, right? And then as we discussed, 21, then blood pressure is normal, but the sex will be high. I'm sorry, sex is high, right? How about 11? 11 is right there, right? Okay, if 11 is not there, then what's going to happen? This comes in here, and this will be increased, and then everything will be okay. So this will be increased, but cannot come here, right? So what's going to happen? So it will be on. So 11 will be the increased, right? 11 corticosteroid is increased, right? Corticosterone is increased. So the problem is this thing is a problem. This thing is a kind of weak the mineral corticoid. So this will also, I think this I'll just write in here. And so 17 blood pressure, sex increase, normal. 21 blood pressure, normal, sex increase. 11 11 is the block, then this thing will be high. So this has a weak mineralocorticoid. So it has a blood pressure increasing function. So it will be increased. And then because if this was the block, I mean, this was this is block, then this will be diverted to here because you cannot have you cannot come here, right? You cannot come here. So it will be increased, and then I mean this will be increased. So this will just divert to sex. So this is increased, and then it will divert to sex. So sex will be increased too. Okay. So whenever the easy way to remember one is the up arrow sign. One, whenever you see one, is up arrow sign. So 17 up arrow sign is right here, right? First letter, first number, right? The up arrow here. 21 up arrow is in the second the digit, right? Yes. So blood pressure, first number, blood pressure. Second number, sex. 11, post number one, right? Post arrows, up arrows. Okay. So this is the easy way to remember this. Okay. So you will, because I, I first try to kind of, just to try to remember only this thing, but that will not do any good thing for you. Because what happens is, this is already too popular. So everyone knows this already. So they will, the exam makers is not them, right? So they will try to make a trick you in every possible way with this table. So they will try to, sometimes they the three beta, and what if it's not there, then which will be increased, which will be decreased. And then 21 already popular here. And then 11 is already popular here. 17 already popular here. So they don't test it anymore. It's like too easy for you because everyone knows already. So you gotta know this, every details of this. Aromatase is not there, then this will be increased. This thing, I mean, this thing and this thing is testosterone will be increased, and androstenedione is increased. And then 5-alpha reductase is not there because of 5-alpha reductase. Testosterone becomes DH, the DTH. I mean DHT. Sorry, DHT. DHT is a strong the male hormone. So if it's not there, then testosterone will be increased. Okay. So just for go one step go further, DHT will in embryology, right? So the metanephros, and then there's like a paramesonephros, metanephros, and then the paramesonephros and the metanephros is a kind of paramesonephros is for female, the metanephros is for male, right? So this one will make develop into the male organs, right? Okay, this will be if this is stimulated by DHT, what will make? What's the like basically this will make the uh, external organs. External organs means PPS. PPS means prostate, the prostate, and then penis, and then scrotum. Those are the external organs stimulated by external the DHT. And then if it's not DHT, everything else is stimulated by testosterone, weak the male hormone. Okay, that will cause I think it's LES, something like that. It's I mean VES. So vas deferens and ejaculate duct, the epididymis, and this is like something else I forgot. Okay, seminous tubules. Okay. Right. So this table is it's better to like the practice throw it few times, you will see it. Okay. All right. Now the this is what we just described, right? And then insulin physiology. I already discussed this like many times. And this one you need to know this like by heart. This is like this will just come up. Basically, if we think about, okay, let me put it this way. If we think about the medicine, do you know another name for medicine is internal med? Do you know that? Internal med. So when you go to like when you apply the residency positions, right? Internal med is another name for the medicine. Same thing. They are same thing. So internal med means, I mean, the medicine is like that's what we are studying, right? So internal med is like another name for that. So in other words, the so in internal med, what's the most important thing? Meaning that what's the most common the concern for the patient population? Like the metabolic syndrome, right? Syndrome simply means that like diabetes or hypertension, the hyperlipidemia. Those are very common metabolic symptoms, right? So cholesterol, anything with the cholesterol, super important. Anything with the diabetes, hypertension, those are like basically that will count more than 50% of your whole entire the IM. Okay, so among those, diabetes is one of them. So diabetes is like a king of the disease phase. Okay, so knowing inside and out about diabetes will make your life much easier. Okay, so um, let me just recap how the insulin is secreted. Now, secreted, secretion, not making, but secreted. Okay, so this is a beta cell, pancreatic beta cell. Okay, pancreatic beta cell. Insulin is the insulin secretion. Okay, not the like the making. Okay, not synthesis, only secretion. Okay, so increasing in the beta cell, there are a lot of the insulins already inside. Okay, so what happens is the um okay, there we go. So what happens is when the insulin I mean when the glucose comes in. So in other words, this thing. Okay, let me quiz you. Do you think is there any like some glucose the channels is stimulated by or activated by insulin? Do you think this will be activated by insulin? Insulin? Do you think it's activated by insulin or no activation required by insulin? What do you think? This particular the channel. So this is a glucose. The glucose comes into the beta cell. What do you think? This can be activated by insulin or doesn't need the insulin to be activated.
I
Just to
don't
use
think it needs insulin to be activated.
what?
I don't think it needs insulin to be
Yeah,
activated.
yes, 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 yes. Why? Can you just the just guess why?
Um, I'm thinking it has to do with the decrease of glucagon. So when glucagon is decreased because of the presence of the food,
Mm,
then the
actually, don't think like very complicated. Okay, this is the answer to this is very simple. Basically, you know, basically too much. This is a blood vessel. Okay, in the blood vessel, too much the glucose, too much sugar. So after you eat, right, too much sugar comes in, right? Then sugar has to be sugar is basically stimulator. Too much sugar that has to stimulate the insulin secretion. Glucose, yes, yes. So don't try to memorize it. Oh, glucose is where glucose, glucose, I have a serious problem in the memorizations. I think I will discuss about um the glucose, the blood glucose, uh, diabetic drugs. I had like very hard time in memorizing drugs. I'm really king of the non-memorizing things. Very hard time. I had a really hard time the memorizing things, and so I cannot memorize things. So So instead of memorizing things, I decide to, okay, so I'm really bad in memorization. So I decide my tactic to study is try to understand it. Because understanding is much easier for me than memorizing. Once you understand it, once you kind of, try to understand why is it happening, then memorization comes into it just very easily. Okay? Without knowing this, and then memorization will be just very difficult. It's like a torture for me. So basically, what happens is too much blood. You eat too much blood, the glucose, because sugar level in the blood will be very high, right? Because the GI cells will just the take up, and then uh, that like take up the glucose, and then glucose will be in the blood vessels, right? So blood vessels coming in, I mean the sugar is coming in the blood vessel, then it will stimulate this channel to just bring into the glucose into the beta cell. You don't need the uh, any kind of insulin activation, okay? Because this is where this is kind of insulin bank. Insulin bank. Let me write it here. Insulin bank. And then it is also insulin factory and bank. Beta cell is an insulin bank and factory, both. Okay. But now we are discussing about the bank function. So in other words, uh, there are a lot of insulins already made. Now, how, in which conditions the insulin will be secreted? Okay. So when the glucose comes in, obviously glucose comes in, then it will become glycolysis, TCA, and ETC cycle, and make a lot of ATPs, right? Making ATPs. That will, oh shoot, making ATPs, and then that will ATP, this channel, potassium ATPase. This channel is called, don't know this as a just potassium channel. It is a potassium ATPase. Okay. So it will inhibit this. So if ATP, surprisingly, if you have ATP, that will the like block the potassium to leak out. So that's why it's ATP is kind of, usually ATP usually opens something, right? But this case, ATP will block, ATP will close the this potassium ATPase. Okay, so this will be blocked, right? then there are more potassium inside, right? Right? So then that potassium is high. So so in terms of like any kind of other like the action potential thing, right? So polar means what? This is a resting membrane potential. Polar means polar means like more negative, right? More negative, right? Dipolar means less negative, right? Less negative. So this is more negative or this is more negative? This is more negative, right? This is a positive. It's like this is I think this is a positive, and then this is like a zero. Say this is zero, then this is a positive. This is negative. More negative is the hyperpolar. Less negative is a dipolar. Going toward the positive side is called dipolar. Okay. So let me see. Why is it not? How can I add her on hold? So there's a okay, I don't know. So the Killin is on hold, but I don't know how to add her. So anyway, all right. So disable make present. Oh, okay. All right. Anyway, so it'll it'll where are we? Okay. So it'll make a dipolar. So in other words, it'll make a dipolar, then action potential will occur. So this action potential will occur. This action potential will make this channel open. So when this channel is called calcium channel, okay, calcium comes in. So this job is make it dipolar. Okay, and then the calcium channel will open. It will make the depolarization, and then action potential will occur. Action potential will just open this channel, and then calcium will come in. When the calcium come in, it will whenever the calcium come in, calcium does some actions, right? What actions? In this case, is it will exocytosis the vesicle. This vesicle contains the insulin. Okay, this is a pre-made vesicle. So factory function already made the vesicle, the insulin, and then put it into the vesicles. Okay, there's a totally different the discussion that factory function, the beta cells factory function already made the insulin and then put that in the vesicles, a lot of vesicles in here. And then when this potassium channel closed, potassium level will be high, that will become more positive because of positive charge is added, right? So that will make action potential to kick in. Action potential will open this channel. And then when this calcium channel will open, calcium will come in. Calcium will do the action. What kind of action? It will does the exocytosis of the vesicles which contains the insulin. Okay? Simple, but very, very, very important concept. The reason this is very important is that there's a drug called sulfonylurea. Sulfonylurea. Okay? Sulfonylurea will inhibit this action, this process. So sulfonylurea will inhibit this. So in other words, it will close. So it will make how do you call it? Sulfonylurea will inhibit this, which is the same as a dysfunction. Okay. So in other words, it will act help to secrete the insulin. Okay. Because of the diabetes drug, diabetes basically no insulin, right? So you want more insulin to come out, right, from the beta cell. Okay, that's what it is. Okay. Now that's one part of the insulin function, but the insulin has like two different pathways. Insulin is like basically two pathways. Two pathways means one here, that's one pathway. Another in here, this pathway. So this is too many things too many things to memorize, right? So let me just let me put it this way. IRS is the same. Insulin bind to it, then IRS is the same. But IRS and the RAS MAP kinase. So this is the MAP kinase. It will be right there. So MAP kinase pathway, RAS MAP kinase pathway. This is called RAS MAP kinase pathway. Basically, you don't have to know all these things. Too many things to memorize. Forget it. Just to simplify it. IRS pathway. IRS always start with IRS, insulin. And then one is RAS MAP kinase pathway, where in which it's a kind of anabolic pathway. Anabolic pathway is a RAS MAP kinase pathway. So let me write down here. RAS MAP kinase anabolic. So start with IRS always, right? IRS, and then it's anabolic. Anabolic means the making some cells. Okay, and then another pathway for the insulin will make the something to do with the glucose. So what does insulin do in terms of glucose? It will make the glycogen, because basically bring the glucose in from the blood vessel into the cell. So not necessarily the beta cell, any cell, more particularly in the fat cells or the hepatic liver cells or muscle cells, that where that's the most popular site that brings the sugar into the cell. Okay, so that the body can utilize it as an energy source. Okay, so basically this this part is energy. For energy, for this is the cell growth. Okay, so this part is the the PIP pathway. PIP pathway. PIP pathway is energy. For cell growth pathway is a RAS MAP kinase pathway. Okay, that's all you need to know. You don't need to know like the mTOR, the BDK, A1. That will be just the too much memorization. Okay, so all you need to know is this two pathway. But another thing you need to know is self auto phosphorylation. So insulin receptor is kind of timer. Okay, so what happens is the insulin comes in here, right? Insulin comes in here. What happens is that there is when there is a kind of timer. Timer means like two things, right? Two things together, kind of twin. Okay. What happens is that this is a tyrosine kinase receptor. Okay. Insulin binds to it, and then this tyrosine kinase receptor will auto-phosphorylate, adding the auto-phosphorylated. So that means that adding the phosphate twice to PP added. Then only after that it will be activated, and then IRS1, and then it goes to PIP pathway, and then another pathway for this is energy, making energy, and then another pathway this way is going to be RAS MAP kinase pathway. Okay, and then for the growth. Okay, that's all you need to know, right? Okay, now this one too complicated. Basically, the hypoglycemic, if it's too much the blood glucose, insulin will bring the glucose into the cell. That's all you need to know. And then it will do it will do the like make it will so lower the blood glucose. The reason that you have to lower the blood glucose is two reasons. One is glucose. You need to utilize the glucose. That's the energy source, right? That's a good thing. Sugar is good. So glucose is good thing, right? So you need to remember, you need to utilize it. So that's what insulin does. Insulin will just bring the glucose into the cell, so you can utilize the energy, make it energy. So that's a good thing, right? So the problem is that in the diabetes patient, insulin is not insulin receptor, the receptor that I talk about, this thing is not functioning. Or that's the type 2. Or type 1 is the insulin, the function, the factory is not there because of there's an antibody against the insulin receptor. So antibody is not there. So you cannot, I mean, antibody is there. So you cannot make the insulin. Okay. So insulin type 1, insulin is not there because you cannot make it. You cannot make insulin. What's going to happen? Or the type 2 is like also the same, right? But the what's going to happen in a lot of sugars in the blood vessel, right? What happened to the increased blood? Yes, yes, yes. So everything we measure in terms of the ions or the any substances we measure through the blood vessel only, right? Or the urine, right? That's the only two things. We cannot measure it in the inside of the cell, or you cannot measure anything. We'll only measure inside of the blood vessel. So what's inside the blood vessel is important thing. In the blood vessel, high blood, glucose, because the glucose cannot come into the cell because of two reasons. One, type 4, type 1, insulin is not there. So there's no mechanism and those things that carries the into the cell. Insulin is not there. So type 2, insulin receptor is a problem. Resistance. It refused to bring the insulin. So that's the type 2. Okay. So in terms of type 2, if the insulin resistance, what do you think insulin level? So this is an important thing. So I will just type 2 insulin level, increase or decrease? What do you think? Insulin level will be low? You sure? Shirley, are you sure? Did you learn this like the central diabetes insipidus and the nephrogenic diabetes insipidus, right? In central the diabetes insipidus, what's the problem? ADH is not there. ADH is low, right? That's why the aquaporin is not building and the water is not absorbed, right? But in nephrogenic diabetes insipidus, the receptor is not functioning. ADH receptor in the nephron is not functioning. So water it cannot it cannot generate aquaporin, and then it cannot reabsorb the water, right? Just in this case, in central diabetes insipidus, ADH level will be low because it cannot make it. Okay, but in nephrogenic diabetes insipidus, what happens is the receptor is not functioning. So body thinks that, oh, receptor is, we need to make more ADH to make it work. So it'll keep making a lot of the ADH. ADH level will be high in nephrogenic diabetes. Same thing in here. Type 2, insulin level will be very, very high. John, I know what you're thinking. So the insulin, I'll get back to that point. Right now, I'm explaining now. type 2, insulin level will be high at the beginning. Initially high. Okay. Problem is it will keep making it because insulin level is low. I mean, insulin is not functioning right now, so it will keep making it, making it. So after some time, everything in body has some kind of limit capacity. So it makes a lot of insulin, but it's not functioning because the insulin receptor is not functioning. Even if you have a lot of high insulin, doesn't work. The body keep making it. It's a kind of the very bad malignant, very very bad cycle, right? So insulin is already making very very beta cell works really really hard, and then beta cell just give up. I cannot make it. I cannot do this anymore. It's just beta cells give up. Now beta cells give up, then beta cells is gone. It's already dead. So they don't make it insulin anymore. At that time, you need to give the insulin. That's the only way. For type 1, from the beginning, you don't have insulin. Okay, no insulin from the beginning. So you have to supply the insulin. But the type 2, at the beginning, too much insulin. You just you cannot, adding more insulin doesn't help. Similar situation as the nephrogenic diabetes insipidus. So because you already high levels of insulin at the beginning, okay? But then once the beta cells are burned out, then now you don't have any the capacity to make the insulin. So that's the time that you need to supply the insulin. Okay. So type 1, type 2 difference. Okay. So that's very, very important thing. Okay. All right. Now then the complications. Very, very important. But in very simple terms, most of the complications come from NEG, non-enzymatic glycosylation. What does this mean? Just to digest the word, break down the word by word. Non, easy, right? Enzymatic, so no enzymes are involved. Glycosylation, simply means so in no enzyme involved. Glycosylation means sugar damage. What's sugar damage? Sugar means that, if you have a juice, right? If you put that in the juice say spill the juice or something like that, and then if you put it in the long time, it will just become sticky. So simply means simply non-enzyme glycosylation. In another word, is a sticky. That's it. Sticky blood vessel wall. That's all you need to know. So if it is a sticky blood vessel wall, what's going to happen? Blood vessel here, and then there's some the endothelial cells here. Sticky blood vessel. I mean, this glucose sugar will just cover this up, sticky, dried up, and then it will become cover up. It will narrow the blood vessels, right? Because it's just blocking. Similar process as like atherosclerosis, right? So it's like narrows down. So it will block the blood flow, smooth blood flow. At the same time, it will block this, like, the blood vessel. There's like many channels, right? Channels or receptors, or many things are there in the endothelial cell. In the endothelial cell here, blood vessel here, that there are many channels and then receptors that because in the blood vessel there's a red blood cell, there's like many nutrients there, right? We need to bring this in. If it's not bringing, then that will just accumulate too much, and then that will make some damages too. Okay, so this will be covered up, so you cannot communicate with the tissue and then blood vessel, no communication because it was blocked. So that makes a big problem. So then, no, where it goes, it will make a problem. If it goes the retinopathy, it occurs. And the hemorrhage, X-ray, because what happens is that this the blood vessel is covered with this the thick the sugar, then that will weaken the blood vessel. So blood vessel, all blood vessel will be weakened because the has to be like the one of the materials that comes in is nutrition, of course, and then also importantly O2. O2 is not there, so it's almost like the like choking you. So no O2, ischemic damages. So cells die. Okay, then that will become this, and the blood vessel wall will be becomes weak. Okay, so neuropathy. Because what happens is that this one, neuron is the first tissue that will be damaged when the O2 is cut. O2 is reduced, then first thing will damage is a neuron. So diabetic neuropathy. Where is that? Diabetic neuropathy. Here, right here. Okay. Diabetic neuropathy is the first one. And then also another, so basically this one, no matter where you go, it will just make the blood, all has to do with the blood vessels. Blood vessels will make the weak blood vessel wall, and then it will leak out. Because it's if it's a weakened, then it might just leak out because this is damage, ischemic damage. Then this part is just gone, and then the content will leak out, make this hemorrhage. Okay, that's one thing. Another thing is that another type of the damage can be occurred by this sorbitol. What's sorbitol here? I mean sorbitol here. So what happens is this is like glucose, and then the glucose becomes the aldose reductase will make glucose into sorbitol, and then sorbitol dehydrogenase will become fructose, make it fructose. Okay, so this is a kind of the normal process. What happens is that this thing is not there, and then sorbitol will become increased. That will make that will make the damage to the the lens. It will cause cataract. Cataract. Okay, so it will make the like a sorbitol accumulation. So normally the cataract. I mean normally the lens has to be very very clear and transparent. But sorbitol will accumulate here, 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 here. That will make a thick white the lens. So the only way you treat this is to replace the lens. Okay? That's a cataract surgery. When you become old, a lot of people, even the like beginning stage of the diabetes, will have this the cataract developed. Okay, so cataract developed. So then you have to replace the lens. Okay, so so that's another thing is that a lot of infections because blood vessel is not working. It's not working. It is leaking, and a lot of sugar here. More importantly, a lot of sugar in the blood vessel. What does sugar will attract? Bacteria, fungus. They love sugar. Okay? They come in. They are the sugar is here. Then they are just their food. The bacteria come in, fungus will come in, and then they eat sugar. Okay. The only thing that you might not be very, very affected is a virus, because virus, is not really, particularly the liking the sugar. Okay, but bacteria and the sugar, the fungus will like the sugar. Okay, all right. So also candida. Candida is also very it's a fungus, of course. And then this will be also very very kind of how can I say? It's a very the sugar liking, so it's sugar loving, and then especially in the mucosal area. So like oral candida, or the vaginal candida. So what happens is that the mucous area, right? Very a lot of it's very not kind of keratinized area. That area, the mucus, has a lot of the tiny blood vessels. Its blood vessels are all leaking or the full of sugar. So that's a like that's a food, very favorable food for bacteria and then fungus. They will come in, then they will eat the sugar, and then they will block that blood vessels, and then cause the problems. Okay. And then candida will proliferate. It's a basically normal flora in the body. Everybody has to have a candida, but too much of this will cause the problem. Okay. All right. So DKA is a topic that has to come in the blood. I mean, in the cast, and then step one. If it doesn't come, if you step one doesn't have these questions, there's something wrong. You have to have this the diabetic ketoacidosis. It's a it's a huge topic in terms of the step one, also cast, and then also in the clinical too. You will see many if you do the rotation in the medicine court. Medicine means IM in internal med. You will see diabetic ketoacidosis patient many times. Okay, so one thing, very important thing you need to know is this. When does this the diabetic ketoacidosis happen? Okay, there are type 1 and type 2 the diabetes, right? Type 2, like I said, you still have some insulin. No, type 2 is not really lack of insulin, but has some insulin. So unless it's very the like toward like end stage of the diabetes, so he's gonna die soon. In that case, otherwise, you have some kind of insulin. Okay, so you are usually okay. But type 1, no insulin. Suppose this guy, type 1 diabetes guy, didn't take you have to take the insulin, but then forgot to take the insulin. Okay, forgot to take the insulin, or some other kind of say he the exercise or something else. So then you have some the like the say you have like if you had like the if we had, say, for instance, the alcohol, you use alcohol, and then alcohol has a lot of sugar. So whatever the reason is, your glucose is very high. You needed insulin to bring the glucose into the cell. Now you forgot to take the insulin. What's going to happen? Glucose will be very high in the blood vessel because you didn't take the insulin. And then although the real problem is your body cell. Your cell don't see the sugar. If you exercise, your cell the will consume whatever the energy source it is, right? So it has the like some the glycolysis, I mean glycogen inside, and which will be depleted like within 2 days. Or if it's not glycogen is enough, then he will use another source of the glucose to make the glucose, which will be glyconeogenesis. If you do this, and then it will make glucose. But problem is, so it will make a glucose more even even higher glucose. But cells still not see the energy source because the glucose is not in the cell, only in the blood vessel only, which is useless, right? Not only useless, it will cause the damages because of non-enzymatic glycosylation. It will damage the body, not helping you. It will just harm you. So what's important is inside of the cell, you need a glucose, but it's not there. So body try to make it, first use the glucose. If it's not there, then glycogen, you tap the glycogen, break down the glycogen and make the glucose. And then if it's not there, if glycogen is not there, you do GNG. GNG, but still not the glucose, then finally you will do ketogenesis, ketone bodies. Okay, you'll make a ketogenesis, then it will make a, there are three types of ketones, right? Beta hydroxylase, the beta butyryl hydroxylase, and then the acetoacetate, and then acetone, right? So you will make this is the last step to make the energy source, because the body needs energy, cell need energy. So this one will make uh, this ketones. And then unique thing about the ketone is that this acetone. Acetone is a gas. So if it's too much in the body, it will has to be come out from the body through the respiratory, through the breathing only. So you will have a cosmal breathing. And then with the fruity smell, because acetone is a fruity smell substances. Okay, so the blood glucose level will be very, very high. Okay, and the also another thing is that if you this is cell, insulin will bring the potassium into the cell. Insulin is not there, then potassium will be outside. So if you measure the potassium level in the blood, potassium level will be high. But this is kind of fake potassium level, fake hypokalemia. Because what happened is that this is not really, if insulin were there, then this is supposed to be going into the cell, but it couldn't go to the cell because the insulin is not there. So although potassium level is high, like say 5.5, normal level is 4. But still, it's not really because of the insulin, I mean, the potassium was actually high. It's because of simply there was no the insulin. That's why the potassium level is high. In that case, even if it's high, you still have to give some insulin. I mean, some potassium along with the insulin, because this potassium might be not because of it was high, because maybe cell die. When cell die, inside the contents of the cell will leak out to the blood, right? Inside the cell is higher potassium than outside the cell. So potassium will leak out. That will make the potassium level high. So this is not like truly you have too much potassium. Okay? So in that case, make sure that unless this is like really, really high, the potassium level is really, really high, then might be actually really need potassium level. But otherwise, it will be just due to the ischemic damages, cell died, and then that potassium leaked out. Why do you think the people concerned about the potassium so much? Always think about the potassium. Why? Can anyone tell? Guess? Any guess? Why the potassium is so high? I mean, why is the potassium is so important? Whenever we talk about the ions, right? Electrolyte, we mostly concern is like we concern two ions, sodium and then sodium and potassium, right? Sodium, understand. Sodium is kind of easy to understand because sodium is like something to do with the osmolarity, right? Why do they concern about the potassium? Any guess? This is important. What do you think? Why do you need so much concern about potassium?
Doesn't it lead to
Yes,
flacidity of the
true.
muscles?
Yeah, that's true. But can you what you say? Can you say it again?
I was saying, doesn't it lead to flaccidity of the muscles?
Plus, yes, true, but the partially true. What's most important? Okay, what can you kill? What people? How people die? Something to do with the when you have some problem with the muscle. Do you die? No, you get a pain. You don't die. When you have a problem with the kidney, you could have some pain or some serious problem, but you don't die. What kills you is a heart. Something to do with heart, then you will die, right? Potassium, something to do with the heart. Potassium damages heart. You remember peak T, then this thing? Heart arrhythmia, yes, 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 yes. That's arrhythmia. Hyperpolarization, that will kill people. So like if you see the EKG, you have a peak T, right? That's all because of the potassium. So potassium level, deranged potassium level is super dangerous. That's why they care about the potassium. They don't care about too much about the other ions. And it's the third injection in the third injection. Yes, 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 yes. Yes, that's exactly right. Yes, I think they still use it. Still use it when you kill people in. I mean, the people who the lethal injection. When they kill people, they use the injection, the potassium injection, to kill the people. All right. Okay, so this is a very, very important thing. This DKA, very, 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 very important. I cannot emphasize it more than this. I mean, it's not enough. Okay. So another similar condition is hyperosmolar, hyperosmotic glucosemic state. This is very similar to this, but only problem is he still has insulin. The only thing you need to know is that he still has insulin. So in other words, as long as you have insulin, you don't have a DKA. So ketone levels are okay. Okay, and then blood glucose levels is high. This is usually for type 2 diabetes patient. This was type 1 diabetes patient. Okay, and then also osmolality, serum osmolality is very, very high. Okay, that's something you need to know. All right. Now, yeah, this is what I was talking about. This page, seriously, this is like I seriously have a problem with the memorizations. And then I tried to memorize this like over and over and over and over again. I couldn't memorize it, and I still cannot memorize full. But I just the one of my study partner just kind of use some kind of the mnemonics and that kind of things. So whatever the resources you can use, but it's the best way is just try to look it over and over, so make it yours. So this is very, very high yield, and also differentiating point and the mechanism of action. And for instance, the one of the key points is that weight loss. Does it cause weight loss or weight gain? So that's also important. So the question will not ask you, okay, what does sulfonylurea do? They don't ask that kind of questions. They will ask you one like obese female comes in and he is looking for his blood glucose level is very high. So what's the best drug you use? If it's the obvious, then you don't want to use like something that causes the weight gain, right? So you have to use like something that gives you the weight loss. So this metformin is probably the first choice, drug of choice. But there are some serious side effects, like lactic acidosis. Although it's not very common, but that could be serious problem. Okay, so that kind of things you need to know. This one is like a really, really important table, but you have to kind of you know you know it inside out. Very, very high yield. Okay, so because you will learn this in the over maybe 2 classes, I think, so, but very, very important topic. Okay. But we are supposed to do repro in this session, but I was spending too much time on the picking up from the endo. Okay, and then now this is a repro. Okay, so this is just the early development. Okay, so not the particularly important, but I just gonna go through this one. This one will, if you, okay, this, bad one is over. I don't have to memorize this. No, 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 no. This will just haunt you over and over again in your whole life. As soon as your medical career, it will just come out over and over again. So, really, really, you have to kind of, so basically only way you can, memorize this. This is really, other than memorization, I don't know how else you can make it yours. This is really, basically maybe you kind of need some kind of other memory tool in the first aid, the like that's, other than that, I don't know how else you can do that. Like in pharyngeal arches is the most, probably the most common thing, that like the first arch is something to do with maxillary thing, muscles, M, everything is M. And then second one is something to do S, stapedius muscles, and then facial, which is a, 7. 7 is S, start with S, right? And so that kind of things. And the 9 and 10. So other than those things, you need to really write down over and over again. So there's uh, no other no better way to memorize this. But it's just, you gotta. I think the best way is like to use the first aid choice, first aid the memory tools. Okay, something different, something you have to do this. And then I think I went over this one a little bit. So what I remember is like bisonepric. Bisonepric is like uh, I mean, bisonepric and parambisonepric. Bisonepric is in the center. Parambisonepric is like in the side. Okay, so how I remember is like bisonepric, penis is the one in the center. Then the female have like the gland. I mean the majora, the labia majora is like a two, both sides, right? So that's how I that's how I remember it. And then the mesonephros will develop into the sieve is the one that I was looking for. Yeah, sieve. That's the internal male organ. And then the external male organ is the that's the testosterone will develop internal male organs, but external male organs will develop the PPS. Okay, so um, so PPS stands for like the prostate, and then penis, and then the seminal tubules. I mean, sorry, scrotum, and then this one is the seminal tubules. Internal organs is this is the internal organs. Okay, right? So this one, and then also another thing you need to know is that this thing, sometimes this is not very, very high, but for some reason, the from few years ago, this is kind of the getting popular. So it's very simple, the analogy, and but in it, by just knowing this, spending only a few minutes, you will memorize it, and this will be just a high some for some reason, all right? And this one, the where is it? Yeah, this thing, disorders about genital embryology. This is a this will be very, very the high yield. Now let me see. Like if there's if there's no table here, okay. So I think the first aid is some kind of table or very simpler format. So what causes this is important, and then what's the presentation. So how you distinguish this and this. So that's very important. Okay, so uh for instance, androgen insensitivity, the best way is like the look at the picture of the person, that how it will be different. Okay, so for instance, like fiber reductase deficiency, That means the 5-alpha reductase convert the testosterone to the DHT, right? So DHT is not there. What do you expect? DHT is not there. DHT will do PPS, right? So this will be the sieve, right? So DHT is not there. Sieve is okay. This will be problem, right? So that's how you distinguish this the problems. So high alpha reductase, DH is not there, prostate will be not there, the penis will be not there. So scrotum is is not there. Okay, that's how you distinguish it. And then androgen insensitivity syndrome is again, this is the receptor problem. Receptor. So receptor problem. So what say testosterone androgen means like a testosterone or DHT, right? So testosterone level will be low or high. Same thing, you know, the like nephrogenic diabetes insipidus, the ADH level will be high, right? Same thing in here. Diabetes insipidus, I mean diabetes, the mellitus type 2, the insulin level will be high because it's not working. So body try to make it more and more. Okay, so this testosterone level will be high, androgen level will be high. Okay, so there's something, something that's, keep in mind that's the problem. Okay, because and then because I want to spend more time in the cancer part, which will be very very important part for you, and then also what happened here? So uh I will do the where is it? I will do some this menstrual cycle briefly, and then I go to the cancer part. Cancer is a very very important topic. You need to know, but the estrogen is a menstrual cycle is kind of, if you understand this thing, very easy. Understand this way. Estrogen, troublemaker. Just a minute. Okay, estrogen is yeah, estrogen is what you need to know. Estrogen, troublemaker. Okay, and then the progesterone is the basically how do you call that? When you make a trouble, you resolve the problem. So uh, basically manager say. So what I mean is that
Maybe
estrogen,
peacemaker.
what?
Maybe peacemaker.
Oh yeah. Peacemaker. Yes. Peacemaker. Okay. So what happens is that estrogen is don't know anything about, don't think about it. Estrogen has no brain. Okay, estrogen is like keep making. What I mean is that estrogen is making the endo, so like uterus, right? Uterus has like 3 layers. Very top layer is called functional layer. Functional layer is basically uh, is kind of how to call that, endothelium, plus some proliferative layer. Okay, so this is where this part is just growing, and then you menstruate out. When this shed, it will be menstruation. This is mens. Okay, when you see in the menstruation material, when the blood comes out, right? That blood comes out, if you look at it carefully, it's not purely watery blood, right? So it has some kind of, the clotty things, right? That clotty things is the endothelium. That endothelium and the functional layer. So that endometrium, this the thick endometrium, will be the shed out, and then that will become menstruation. Okay, so that's why you see it's not just something like bad. You see the some clotty material, some flesh material. So it's not any disease. It's just normal because it's not just a pure water, pure blood. It has like this thing has to be shed out. Okay, So that's normal. Okay, so that's the functional layer. And then second layer is called muscular layer. And then the epithelium. Okay, so what happened here is, okay, yeah. So what happened is that the when you when the estrogen stimulated, it will just build up, keep building up until progesterone comes in. If there's no progesterone, estrogen will keep building up. So what's happening in let me draw this, because this understanding this will very make it easy for you to understand the menstruation, and then also amenorrhea condition. Sometimes people will be very confused with the amenorrhea. Amenorrhea means no mens, right? So let me explain why it's easy to understand, why it's not easy to understand. Okay, so amenorrhea, menorrhea. Okay, so normally mens here, and then estrogen build up, right? Estrogen will make the endometrium building up, because the estrogen is a troublemaker without thinking, without brain, just keep building up. Now estrogen will stimulate. Oh, I told you about the positive feedback, right? There's one more positive feedback in here. So estrogen will positive feedback to luteinizing hormone. So estrogen will peak here. That will make the luteinizing hormone, LH, also positive feedback. So LH will be surge as the estrogen goes up. Okay, that's also positive feedback. Okay, that's the important thing. And when the luteinizing hormone is high, that will make a ovulation. Okay, so what does ovulation mean? Corpus luteum. And this is ovary, and then there are a lot of follicles, right? Follicles about in human life about 400 follicles. Okay, so every cycle you have two ovaries. Every cycle, either one of them, not both. Usually, normal situation, one of them has a follicles. About 2 to 3 follicles will be selected. Okay, now this time, this one is selected. And only one will go through the ovulation process. The other one will be degenerate. Okay, so only one, say this one was selected. Then this will grow big time. Okay, and then there's an egg. Egg will pop up. That process is stimulated by LH and FSH. Okay, these two will stimulate this thing, and then pop up. And then remaining is a corpus luteum. Corpus luteum will be basically corpus luteum is empty nest. Okay, corpus luteum is empty nest. Okay, this will secrete progesterone. Progesterone. Gesterone is a pregnancy, right? Pro means like in favor of pregnancy. Okay, it will support the pregnancy. That's the progesterone. Okay, so this progesterone is basically peacemaker. It will come in, and then, oh, you build up too many. What happens is it will make up too much the endometrium. Now let me see if there is any the sperm comes in. When the sperm comes in, oh, now yeah, you did a good job. Now I will take over, and then I will just make the fertilization process. That's what the progesterone do. But if the the sperm comes in, no fertilization occurs. Oh, then don't stop estrogen. Estrogen, you have to stop. Okay, stop making it. So progesterone will oppose the oppose estrogen. Estrogen. So stop making stop blindly making endothelium. So so with so what you made has to be removed. So that's what progesterone will do. So progesterone, if no no fertilization, then progesterone will remove this into mens. Okay, so that's how normally mens occurs. Now the problem is there's a problem. There's a disease called PCOS, polycystic polycystic ovarian syndrome. Okay, so in this case, what happens is there is no the too many cysts like this one. This the ovary has to have like some the cyst. That's normal. Some cyst is normal, but too many for some reason there are too many ovaries. Because what happened? What exactly happened is estrogen is very strange thing. Estrogen has E1, E2, E3. E1 means estrone 1, estradiol, estradiol. Okay, 1, 2, 3. Estrone is made from fat cells. So people who are kind of obese, right? They make a lot of estrone. But estradiol is the strong the estrogen that is made in ovary and then the adrenal gland and that kind of thing. Okay, so this is a good one, but this is like a very kind of it's not really good or bad, but this is you can say this is kind of bad. Usually, this works like some bad thing. Okay, so estrogen is the problem, main problem. So in some other kind of obese people because there are a lot of estrone E1. Estrone will make the estrone is basically always troublemaker. Specifically, estrone is a really queen of the troublemaker. So this will keep making something just building up without thinking. He will think, okay, so the making some kind of follicles. Okay, so I'll make many follicles so that you have the ovulation. So he keeps making the follicles, and then it makes it should ask the ovary to make more and more follicles. That will become sometimes like the without egg it will just become like cyst. Okay, instead of just the that has egg and then that is developed into the mature follicles and then it will rupture and then it will ovulate. It's supposed to be normal, but this estrone is a problem. Estrone will keep saying, okay, make follicles, and then it has like no eggs, but it's cyst. Okay, so many cysts. So that will block this will block the ovulation. Okay, so it will make anovulatory cycle. Now the reason what I'm explaining this is very important. This part is not even the teachers, the professors don't they explain this in the clear way. So I just look at some other resources as well, and then figure it out. Okay, so what happened is let me draw it. Let me draw it this way. Okay, this is the endometrium level. Okay, so what happens is normally this is the like blood vessel goes here. Blood vessel goes here, and then this is the basal layer, and then the blood vessel there's a spiral artery, right? And supplied from this blood vessel through the uterine artery. Okay. Then, what do you think? This basal layer, and then this the top layer, which is this is just a uterine cavity. Okay. So this is normally this area supposed to be fall of shed by the progesterone working, so that this area shed, and then it becomes men's. Okay, but that's like that occurs like that's why it keeps like 28 day cycle. Okay, now then, if estrone is just working too much, and then it just makes the anovulatory cycle. I mean, sorry, it will make a lot of cyst, and then it becomes anovulatory cycle. But anovulatory, so the egg don't come, but it also acts in the uterine, and then it will make a big, thick the layer of the functional layer of the uterine. So it will become, the uterine wall will be very, very huge, right? So what do you think? If there's a blood supply here, so do you think this will spiral artery will supply all the way to the end? No, because what happens is a spiral artery is not, it will supply this area is okay. This area is okay. If it's too big, then you cannot supply the oxygen or the blood vessel, I mean blood, to the all the way to the end, right? So this part will be dying. Ischemic necrosis. Okay? Ischemic necrosis means that these cells will die. So coagulative necrosis, same as ischemic necrosis. Okay? Coagulative necrosis, ischemic necrosis, and then cells will die. So it will become apoptosis. Apoptosis. And then cells will die. It will come out to the mens. It will come out to the blood because cells died, and then it will come out, right? So as compared to the normal cycle, every 28 days, this the progesterone comes in, estrogen build up, progesterone comes in. Okay, estrogen, no, you built up too much. I'm gonna destroy shed this much of the endothelium and then uterine functional layer. I'm gonna shed this and then make it to blood out. Okay, so that is necrosis. Okay, so oh yeah, I'm sorry. This is a necrosis. Sorry, necrosis. And then this is sorry. This is this is apoptosis, because the progesterone will program the functional layer of uterine to be the dead, to be killed. I mean, say to be suicided. So okay, you got a suicide. This part, you got a suicide. You are useless. You are suiciding. I'm gonna let you suicide. I'm gonna program you to suicide. So apoptosis, and then this will come out to the mass. In the ischemic damage case, no ovulation. So no ovulation means no ovulation means no the no no the corpus luteum, because egg is not there. So corpus luteum is not formed because the egg didn't pop out. So corpus luteum is not there. No progesterone. No progesterone. Only estrogen is working. So building up, building up, building up. This is a huge, the thick layer of the uterine wall, and then the spiral artery cannot provide the oxygen or nutrient all the way to the end. So top part will be necrosis, ischemic necrosis. So they will become necrosis, and then this one, whereas normal situation, progesterone will work, and then this remove this thing as a apoptotic process. Do you see the big difference? So the difference is that this one, because it's programmed every 28 days. This one is not regular, because whenever this is like too thick, then ischemic damage. So you myocardial infarction doesn't come in the regular cycle, right? So oh yeah, I have a myocardial infarction every 3 days. It doesn't happen like that, right? So it's just if it's too too much blockage in the coronary artery, then they'll become myocardial infarction. Same thing in here. Too thick, then you cannot blood the enough supply of the oxygen. That will die. Okay. So necrotic damage, irregular the mass, and then this is a necrotic damage, not the apoptosis. But here progesterone working, that's apoptosis, regular. Okay, big difference. The professor will not explain this clearly, and then I don't think they will. Hopefully they know. Hopefully they know this process, but they don't. For some reason, they don't explain this in very detail. Okay, but this is how it works. Okay, so understand this will make you very, very, a very like good understanding in the PCOS. Okay, very important. Molar pregnancy, I should not use this kind of term, but there are two types of molar pregnancy: partial mole, and then complete mole. Okay, this is like basically 69 XXY or XXX something like that. Okay, so complete mole is only the only the sorry, not the 40, sorry 46 XY 46 sorry, let me rewrite it. Sorry about this. Complete mole is 46 XY only. So basically two males will make 46 XY. Okay, that's the complete mole. Only male, that's the complete mole. Partial mole is one girl, two guys. So this will be 69 XXY, XXX, XX, XX, XYY. So many combinations, equally likely, but the XXY is probably the most common. Okay, so it's kind of I should not use this kind of term. This is kind of partial mole is kind of gangbang. All right, I'll write it. Okay, complete mole only two guys. Okay, so that's what you need to know. All right. So so you will see this kind of the other radiographic features, and one thing important is that when you have this, you have to check the HCG level. When you have this, you will the scrape it out, right? You will have to scrape it out. After that, you will keep check the HCG level, so that whether that mole disappeared completely. If you don't check, it will come back. When you come back, it will become choriocarcinoma. Choriocarcinoma. So it's a cancer. It will kill you. So before it happens, after you do surgery, you have to make sure that the HCG level is low. Then that's okay. But so you will have to keep checking. Okay, so that's the thing you need to know. All right. Now, there's a record. This eclampsia, hypoeclampsia is an important, very important concept. But I like to spend more time in the cancer. Okay. So there are some other vaginal pathologies like the Bartholin duct. Bartholin is like basically lubricant. Okay. So when it's blocked, usually unilateral only, unilateral. And then 4 o'clock, and then no, sorry, 8 o'clock, and then 11 o'clock. So 12 o'clock here, 9 o'clock, 3 o'clock, and then 8 o'clock is this way. Okay, 8 o'clock. All right, 8 o'clock actually is from the vaginal piece. This one from here, 9, 3, 8 o'clock is right there. Okay, so it will be right here, right here. Okay, there's something you need to know. All right. Another thing is that this one, yeah, now is the cancer. Breathing syndrome. Yeah, this is what I discussed about this. Okay, and where's the police? Yeah, ovarian cancer, very, 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 very important. This page is super important, and then very high yield, and very hard to understand at the same time. Okay, so I try to make it very, very simple. Okay, so there are like three types of cancer: surface epithelial cancer, and then germ cell tumor, germ cell cancer, and then the sex cord tumor. Okay, surface epithelial is basically kind of this the outside surface epithelial. That's the outside thing. Okay, germ cell means it's a gonadal cell. Gonadal cell is like the gonadal cell is like the yolk sac. So I mean the gonadal cell is basically like a totipotent, totipotent cell. What does totipotent cell? Totipotent cell can make baby. That's a totipotent cell. How about polypotent or multipotent cell? Multipotent cell. Multipotent cell means potential. It has a potential with total, but here is a many potential. Total means like everything. So it can even make a baby. So that's a totipotent cell. So in other words, the modular, right? 64 stage, 64 cell stage, modular. This is modular, right? So each of these 64 cells are totipotent cell. So theoretically, one female can have 64 twins. Okay, it's possible to have a 64 twins. That's the maximum. You cannot have 128 twins. Not possible, because after this, this cell is all same. 64 cells are same. They are all totipotent cell. Okay, and then this cell will, from that point, that will be dividing. Not all cells are same after this point. Okay, so 64 twins are maximum. After that, it's not possible. Everything is just a multipotent cell. Okay, now this is a totipotent cell. So you can have a baby, you can have a embryo. So you can differentiate into anything. So you can have a baby, like immature baby or like mature baby, or embryologic embryologic things, like embryo stage of the babies, or you can some embryological structures like yolk sac, like placenta, or that kind of things, right? So those are like germ cells. Okay, surface endothelial cells is kind of uh, is kind of surface endothelium means like it's covering. Covering means that in the covering there could be some like fluid or mucus. Okay, so that's the only thing you have. So surface epithelial cell in the female ovarian cancer is just basically it will form the cyst. Okay, so the inside of the cyst can be like the serous. Serous means like fluid or the mucus. That's it. Okay, and then sex cord stroma. Sex cord stroma is like the cells that support. This is a support cell. The support cell is like a Sertoli cells, and then granulosa cells, or sometimes even the Thika cells. Yeah, Thika cells and the Leydig cells. That's possible. Okay. So now those are like big pictures. Okay, and then if it's a yolk sac, Yolk sac, you know the yolk sac, right? It's when the when the embryo, I mean the fertilized egg divide and divide, and then it will eventually form like a kind of, you know, this the amniotic fluid, and then kind of this is placenta, and then amniotic fluid, and then there's a yolk sac, which is kind of yolk. Yolk means like a nutrition. So, you know, egg yolk, right? The yellow part is a yolk, right? That's what yolk sac is. So yolk sac has like some nutrition. So that's what the yolk sac is, right? And then it can have like it becomes the whole body, whole baby, whole, you know, whole baby means, because this is a tumor, it's not really making a really live baby, but whole baby means like any baby part, mature baby part. Okay, so like it can make some kind of the hair particles, or the teeth, or the anything you can think of in the body. Okay, so any part of the baby, I mean, any part of the body can be made by this yolk. I mean, the germ cell tumors. Okay, so if it makes the part of the baby, mature baby, that will call teratoma. If it make undifferentiated cells, so instead of like this the mature babies, but basically this one simply means immature baby. Immature babies. Baby means not. I'm not talking about live baby, because again, this is the cancer. Cancer don't make any good for you. Cancer always make it bad for you, something bad. So meaning that it's not live baby. Okay, it's something like the cancer cells are very very kind of like egoist, selfish cells. So they just make they, even though if they have some kind of original function in germ cell. For instance, original function is making a baby. That's their main function, right? But although their main function is to make a baby, they, because when they become a cancer cells, right? They don't they don't perform their original function. Rather, they will use that capacity to grow themselves. That's all they need. They are trying to grow themselves. So they will, the cancer cells in here, the cancer cells will make the first thing, they will make a VEGF. VEGF means the blood vessels, growth factor. Blood vessel, endothelium, blood vessel, growth factor. They will make blood vessels. So they will make the nutritional highway to themselves. So, okay, so bring the nutrition to me, bring the oxygen to me, I need to grow. So that's what they do, cancer cells. Okay, so these cells, germ cells will, germ cell tumor cells, I mean, germ cell tumor cells will make the highways, nutritional highways and oxygen highways, to make themselves to grow. But their function is they are very very the high level capacity. They have a great capacity of everything, because they are totipotent cells. They can make even babies. They can make all kind of body part. So they will when they grow, they will make they'll use their function to make everything possible. So, you know, they make some teeth, they make some hair, they make some thyroid gland. So the problem here is when they make thyroid gland, usually thyroid gland is the one they make it uh, thyroid gland is the one when they make like this is the only thing of that only possible way that they some kind of functioning thing. Okay, other things are like not functioning, like they make teeth, they make hair, but this is not really functioning. But you know, they make the grown up function, grown up type of tissues, like grown up type of the hair, grown up type of teeth, grown with tongues and skins, whatever. Okay, but thyroid gland is only thing they make functionally. Okay, so what happens is that this will make the this will really make the T3, T4. So what it will cause is that it will becomes thyroid gland level high. T3, T4 is high. So hypothyroidism due to this cancer, okay, which is not in the thyroid gland, but all the way down in the ovary. Okay, so this is called stroma ovale. Okay, because it's from the oval, the ovary, the stroma. Stroma means kind of kind of supporting cells. Okay, all right. So that's what the stroma ovale is. Otherwise, it will be making all kind of part of the body, not live cells, not functioning cells, but part of the body. Okay. And then dysgeminoma is a bad thing because it will be immature baby. It will make immature baby. So anything immature will be bad. Okay. And then they can be benign or malignant. Okay. And then sex code stroma is like the granular cells. The one of the thing you need to know is that this will be kind of this thing will be the difference between the med3 and med4 and the med1, med3, med4, or as versus to med1, med2. Med1, med2, you don't learn pathology. Med4, med3, med4, you will learn pathology. And then in the pathology, they will focus on this kind of wordings. So let me see if there's a, you have to know this kind of thing. Fried egg, the Schüller-Duval bodies, what else? Multiloculated, monodermal type, that kind of things. Those are the keyword though. This is like a very, very keyword that also the tumor markers. Those are like, those things are very, very important. Especially also when the pathology teacher will make the exam like this. And then also it's the same thing in the step two. I mean, step one, step two. So they will use this kind of terminology. So when you see this geminoma, you have to know the fried egg appearance, and then the LDH and HCG and that kind of stuff. So this one, but you kind of have to you can kind of the like uh think why that kind of the tumor markers are increased. For instance, so like I said, germ cell tumor, okay? Germ cell is a totipotent cell. They can make anything, right? So they can make the placenta, they can make the yolk sac, they can make the mature baby or immature baby tissues. So mature baby tissues means like teeth or the hair and then that kind of things, or thyroid, right? And then immature baby is like it's not really this kind of things, more kind of embryo type, right? And then because the embryo is immature baby, right? Placenta, if they make placenta, what do you think the what kind of hormone will be secreted in the placenta? Remember that the corpus luteum, when the egg pops out, then the corpus luteum will progesterone, right? In the first trimester, corpus luteum will secrete the progesterone. And also, corpus luteum produces what? HCG. HCG is the one that the human chorionic human chorionic cells, something. I forgot what G stands for. Okay, so this one will is the one that the stimulate the vomiting center in your the hypothalamus, and then that will make the like nausea, vomiting. So at the beginning of the pregnancy, when you have when you get pregnant, the first sign is like, oh, I became nauseated in the morning, right? So that's what is causing this one, right? So after 8 days of the pregnancy, you will in the urine, you see the like in the pregnancy test kit, and then you read 2 lines here. That's that's how you test it the HCG level. Then you get pregnant, right? So so placenta is the one is taking over corpus luteum's job after 1 trimester to secrete the HCG. Okay, so when it makes the germ cell makes the placenta cells, it will cause the HCG levels go up. When it makes the yolk sac is also very unique for making alpha fetoprotein. Okay, so something you need to know: alpha fetoprotein will be high in yolk sac tumor. Placenta will, I mean, the HCG will be high if it's a choriocarcinoma. Choriocarcinoma simply means placenta cell tumor. Placenta cell malignant tumor is choriocarcinoma. Okay, it will, because it's placenta, it secretes the HCG. Okay? LDH is, although you taught, they teach the LDH, it's not really not, it's a kind of non-specific, because LDH means that when cells die, LDH the increase. LDH is supposed to increase when the cells are dying because of the ischemic. So no, and anaerobic glycosylation will cause the lactic acidosis because of no, it doesn't go through the TCA cycle, and then it will make the LDH high. Okay, so it's not specific, but for the purpose this cast, you'll have to know this, but HCG is a big thing. Okay, and then yolk sac tumor, alpha fetoprotein. And then you also have to know this other fried egg appearance. I'm not sure whether you can see the fried egg. Maybe this one. This one is like a fried egg. I'm not sure. Okay, so the mature cystic teratoma is like you see the teeth here and the hair, all the kind of skin things, right? So that's something you need to know, all right? And then the like the supporting cells, right? When the supporting cells is this thing, Ticoma, cetolytic, and then those are cells, the supporting cells for so this is called sex code stroma cells. Okay, so those cells can become a tumor cells, and then they will become the corresponding the hormones. Okay, so another big thing is this one granulosa cell collectional bodies. That's a very, very important thing. Collectional bodies is this red thing here. Red thing is this red thing. Actually, this red thing is a collectional body. All right. Okay, so I think it's because of this, the breast is important, but the ovarian cancer is really, really important. Ovarian cancer is like really very, very confusing, and I spend only like maybe the 20 minutes so, but the ovarian cancers, you will have to know a lot, because many people get confused with the ovarian cancers. Okay, uterine cancers are, it's kind of understandable, not very, very difficult concept to understand. All right. So that conclude the boot camp. I hope this helps you. So helped you. I mean, so I will be. I don't know how. I will be for sure. I'll be the one of the lead TAs, but I don't know what what the med I will be the lead TAing. But if I do lead TAing for med 4, I will be most of the time just I will do the med 4 stuff, med 4 TA stuff. But I'll probably even if I'm not becoming med 4 TA lead TA, I will just probably switch between med 1 to 3 for alternatively. So I have to review myself too. All right. Okay. Thank you very much, and good luck. And good luck on your Med 4, and welcome to Med 4, and then enjoy your rest of the vacation. Okay, see you next week. I mean, see you the next semester. All right, thank you very much. Thanks for joining. Okay, and I will by the way, I will download this the recording into my upload into my the YouTube channels. I will send out the link because my roommate is Caleb. Caleb will send you the link for my YouTube channel so that you can see all the recordings for this boot camp, as well as some other the topics that I uploaded myself. Okay, and then please click the like, and then please subscribe to my channel. All right. Okay, that's that's advertising. Thank you very much. Okay, bye bye.